there is no way to image non-invasively the distribution of amyloid in patients with light chain amyloidosis. And that was something that we recognized very early on in the lab that would be beneficial for multiple reasons. Firstly, it would give us a full appreciation of these deposits and how extensive they were in every patient. We needed a way to actually demonstrate how much amyloid there was in each organ and which organ was involved. And if you, with that information, you could monitor response to therapy, which has become a major component of patient management in oncology. And so an imaging agent was desired, and we set out to develop one. And we wanted an imaging agent that would potentially image all forms of amyloid. And so we developed a peptide that we call P5+14, which is now known as AT01. And it has the ability to bind all amyloid deposits through electrostatic interactions with two components of all amyloid deposits, the amyloid fibril itself and these sugar molecules that deposit in all amyloid fibrils. So we have two targets in the amyloid. And so we did a lot of preclinical work using animal models and tissues derived from patients. We were able to demonstrate that this peptide specifically bound the amyloid in all the systems we were looking at. And there was no off-target binding in the systems, meaning it didn't bind to anything that wasn't amyloid in the systems that we were working with in the lab. And so we set about getting NIH funding to develop this imaging agent to start the phase 1/2 clinical trial at UT Medical Center. And it was an open label, single site trial. And the inclusion criteria are very loose, as long as you had a diagnosis of amyloidosis. And the goal was to demonstrate that this peptide could do in patients what we knew it could do in the lab, and that is to bind specifically to amyloid. Patients were recruited, and we were able to, after informed consent, we were able to get access to their medical records, and that allowed us to, based on the clinician's notes, define where they had amyloid, so which organs were involved. And then the goal of the trial was simply to demonstrate that when we imaged them with this peptide by PET-CT imaging, that we were able to identify uptake in the organs that were known clinically to contain amyloid. And so we recruited in total 52 patients, most of whom had AL amyloidosis. Some had other forms of amyloid as well, many of them much rarer than AL. And we, once we demonstrated that there was positive uptake in organs that were suspected of having amyloid, then we recruited 5 healthy controls to assess sort of the background binding in healthy organs and tissues. And so the trial was started in 2019, and we did, as I say, 57 participants, and it was ended just 2 months ago. Yeah, so with respect to AL amyloidosis, we had 23 patients diagnosed with systemic amyloidosis. 22 of those patients imaged positively with a peptide in one of the 4 major organs, heart, liver, spleen, and kidney. And then one patient who didn't image was a patient who was diagnosed with renal amyloidosis many years ago, had a stem cell transplant, went into full hematologic remission, meaning the light chain production was cut off almost completely for a long term. And then when we imaged her, there was no evidence of amyloidosis. And that's a phenomenon there was no evidence of uptake. And that was a phenomenon that's quite well known in the patients who have a very good response to chemotherapy or an autologous stem cell transplant. The amyloid deposits can spontaneously regress in a small population of patients. But in the other patients, we saw uptake in one of the 4 major organs. With respect to the cardiac amyloid in these patients, we had 96% positive percent agreement, meaning that in 13 of the 14 patients where cardiac amyloid was known to be involved, we were able to image it there. For the liver and spleen, we were 100% agreement with the clinical record, and for the kidney, it was 70%. So overall, with respect to that AL patient population, we had 96% positive percent agreement, which is well beyond what we were, the target that we set for a positive trial. In addition to demonstrating that sort of sensitivity analysis, we identified 47 organs in the patient population that we imaged in total, sort of including liver, spleen, heart, kidney. We identified 47 organs, and only 28 were recognized in the clinical record. And that leads us to believe, as we suspected, that much of the amyloid in these patients is not recognized by the physicians, either because it's subclinical and it doesn't cause changes in biomarker levels or any kind of symptomology, or that it's it's at a level that's it's just it's asymptomatic essentially, and that there are no changes associated with that level of amyloid, but our imaging agent was sensitive enough to pick it up before the symptoms actually began to occur, and changes in biomarkers could be evaluated.